we have two questions for you. The first question is the treatment approach for early repolarization syndrome, ERS, and Brugada syndrome, BRS, are similar. But the prevalence of the J point elevation was much higher in the ECG pattern of ERS than BRS. So are there any factors that could be helpful in identifying patients with ERS at high risk of sudden cardiac death?
Prevalence of early repolarization syndrome ranges between 2% and 31%, depending on how you define the syndrome. The vast majority of these cases are benign, so it's very important to be able to identify those individuals who are truly at risk. And there are a number of electrocardiographic and other markers that we've identified over the past several years. First and foremost is the presence of J waves, and very tall J waves, usually greater than 0.2 millivolts with high dynamicity. And when these occur in the inferior leads or in the inferolateral leads, they're associated with a higher risk for the development of sudden cardiac death and arrhythmias in general. When the QRS includes fractionation or fragmentation, this is another risk factor. When the QT intervals are very short, when premature ventricular contractions occur that are very closely coupled, this is another indication there may be problems to come.
Recent data showed that a Shanghai BRS score system was applicable for diagnosis and risk stratification. Do you think this scoring system could potentially guide treatment in the future, especially in asymptomatic or low-risk patients?
Potentially, yes, but this would need some prospective validation. So the proposed Shanghai scoring system for the diagnosis of Brugada syndrome includes looking at the electrocardiographic factors, looking at family history, looking at the clinical history, and looking at the genetics. And it classifies patients into three categories. One is non-diagnostic, the other is possible, and the other is probable or definite. So the Kawada and co-workers looked to validate the Shanghai scoring system, and they followed 393 patients with Brugada syndrome for a period of about 79 months. They had 43 cases of sudden death or ventricular fibrillation. The important thing to note is that arrhythmic or malignant arrhythmias did not develop in any of the patients that were classified as either non-diagnostic or possible Brugada syndrome. So that there were, suggesting that it is useful in risk stratification, but I think that this would need some prospective validation.